So I'm going to talk about the sort of pediatric version of all of this. I'm going to start with the acknowledgement slide and just say that, this is the work of a large group of folks from many different disciplines. We come together with our immune dysregulation team that cares for children with immune dysregulation disorders of all comers, all causes. And just a few people that I just want to recognize in specific. Carolyn DiOrio is an oncology fellow that really led the efforts to collect, enroll, obtain samples. Bird Pakti helped process a lot of the samples for generated data I'm about to show you. And then my co-PIs, Hamid Basiri and David Tichy, along with myself in helping to coordinate the various studies. And of course, everybody else on this slide, played a critical role as well. And I could take the whole half hour talking about what everyone did. I'm not going to do that. The narrative for pediatric COVID-19, I think early on in this, in April and even in May, was pretty rosy. The narrative was children didn't get sick. So if you look at census data, 22% of the U.S. population is less than 18 years old, but only 1.7% of COVID-19 cases were less than 18-year-old, suggesting that children were really not developing the severe COVID-19 syndrome, even though we certainly were detecting SARS-CoV-2 virus in children. And even those that were infected, there was a very low rate of hospitalization, even lower rate of ICU admission, very low rate of mortality. And so it wasn't, we were spared in pediatrics. It was good news. Certainly there were some children that developed what looked like severe COVID-19, just like the adults were getting, progressing to ARDS, multi-organ dysfunction, hyperinflammatory syndrome. And in general, these were children with other comorbidities who, likely get sick by many other viruses as well, not necessarily a SARS-CoV-2 specific phenomenon. So, we were maybe pleasantly surprised or happy that at least children were being spared of SARS-CoV-2 complications. And then, as all things with this pandemic, longer goes on, the more stuff you learn that's new. We became aware of a different disease presentation that seemed to be unique to pediatrics. And the first report started coming out late April, particularly from Italy, where they suggested an increased frequency of Kawasaki's disease-like syndrome. Kawasaki's disease is a well-known syndrome in pediatrics that causes systemic inflammation, and in particular affects the arteries of the heart, the coronary arteries. Of course, now I get all these different error messages. And no one really knows what causes Kawasaki's disease. It's been recognized for many decades, and there's a number of sort of phenotypic changes that go along with it: conjunctivitis, a particular kind of rash, swelling, and then this coronary artery inflammation. So the Italian report came out first. Shortly thereafter, a similar report came out of the UK, suggesting that children were developing something that looked like in between Kawasaki's disease and a toxic shock syndrome. The Pediatric Intensive Care Society gave a warning for this thing called Pediatric Inflammatory Multisystem Syndrome, or PIMS. A week after, New York City then began reporting this. And then mid-May, the CDC issued a health alert naming the syndrome Multisystem Inflammatory Syndrome in Children, or MIS-C. And I'm going to refer to this as MIS-C throughout the rest of this presentation. And it was around, this time as well, we began to see cases at CHOP as well. And so the MIS-C syndrome is, as I said, a disease of childhood. The average age that was reported in literature is around 7 to 10 years of age. And it consists of a presentation of fever, severe abdominal pain and diarrhea, features that look like Kawasaki's disease. And then the children were very scarily presenting in shock. So hypotension requiring vasoactive medicines and inotropes, the need for intensive care and respiratory as well as cardiac support. And the epidemiology was that not all these children were SARS-CoV-2 PCR positive, although a number of them were. But they tended to be serology positive, and they tended to have some epidemiologic link. Dad was admitted with a COVID-19 infection 3 weeks earlier, or parent works in healthcare, something to that effect. And so there really was this association being made with SARS-CoV-2, but it seemed to be like it was more of a post-infectious phenomenon, because most of these children did not give a history of having had a COVID-19 or a respiratory presentation prior. They were well prior and then developed this weeks presumably after their infection. From the perspective of the laboratory, they had evidence of systemic inflammation as measured by CRP, procalcitonin, and ferritin. They had evidence of cardiac dysfunction as measured by troponins and BNPs, and some had been reported to have elevated IL-6 levels. And their heart dysfunction, although in some cases looked like Kawasaki's disease or some coronary artery abnormalities, was actually much more striking for ventricular dysfunction, which is an unusual cardiac manifestation of Kawasaki's. As I said, that's mostly limited to the arteries. These children were presenting with problems of their myocardium not wanting to squeeze. So that was the sort of state of affairs by mid-May. At CHOP, we had already had a study ongoing to enroll prospectively any child with a documented SARS-CoV-2 infection and obtain biospecimens for analysis. And so around the end of May, we did a data lock on our cohort. This is what the cohort ultimately ended up looking like, 50 patients screened. Ultimately, I'm going to present to you data from 20 patients. We've continued to collect samples. Unfortunately, we continue to see cases, and I'll say that we'll be able to reproduce all of these findings in the bigger cohort because we've been following these data prospectively. So although I'm showing you a smaller data set, the data do hold even as we continue to collect. And what we were able to do is to break down this cohort into the three groups, and it's sort of a unique way of looking at the architecture of SARS-CoV-2 infection. So there's a group of patients that are basically asymptomatic. These are the children I told you about in the first slide, that kids do fine with infection. Most of them don't even know that they have it. For infection control purposes, if you're admitted to CHOP, you get a SARS-CoV-2 PCR, because if you're positive, we need to cohort you away from the other patients. And so that gave us the opportunity to look at kids that were sort of incidentally infected, but were in the hospital for some other complete unrelated reason. They were not symptomatic with SARS-CoV-2. And then there were the two sort of affected populations. There was a group of patients that basically developed the adult severe COVID-19 syndrome, ARDS, respiratory syndrome in the ICU, unfortunately also associated with mortality. And then there were the MIS-C patients, the patients that presented with this cardiac presentation, the GI presentation, the fevers, and the rash. And then we were able to basically compare these three groups. And so this is a busy slide that just sort of shows the clinical features. And this is just to show you that, indeed the minimal patients were not sick. They did not require inotropic support. The MIS-C patients, as I told you, certainly do, as well as the severe COVID-19 patients. And then, as Mike mentioned, lymphopenia is something we see in the pediatric population as well. Even in some of the minimally affected patients, you get low lymphocyte count. Again, another busy slide that contains the clinical data on these patients, but I just wanted to make two sort of major points here. The first is that invariably the patients that are presenting with MIS-C were previously healthy children. They have no comorbidities. They don't have other diagnoses. They're not on other medications. These were well children that are spontaneously showing up in the intensive care unit requiring intubation and inotropes and vasopressors. So a really striking presentation. That's in contradistinction to the patients presenting with severe COVID-19. As I told you, these patients almost invariably have comorbidities, cancer, diabetes, obesity, lung disease, congenital heart disease. You can see the list on the slide. These are children that are otherwise not well, that are now getting sick with a bad virus and getting sick with a bad virus. These children also might have gotten sick with influenza or adenovirus or other viruses. And then the other striking thing is this abdominal presentation in this. And it's not just like, oh, my tummy hurts. These are children where surgery came down and I was considering taking them to the OR for exploratory laparotomies because we were worried about surgical abdomens, because we were worried about appendicitis or other intra-abdominal processes. We had one child develop portal venous gas. So these are really severe abdominal presentations that I think, again, is not part of the typical Kawasaki's presentation and seems to be like a striking feature that's common to a lot of these MIS-C patients. Again, another busy slide with a bunch of labs. This really just sort of confirms some of the things that I told you before. They're lymphopenic. They tend to get hyponatremic. Interestingly, and again in contradistinction to Kawasaki's disease, these patients tend to be thrombocytopenic as opposed to Kawasaki's disease, where patients tend to have high platelets. Very elevated inflammatory markers, again, in the form of CRPs and in the form of procalcitonins. And commensurate with the amount of ventricular cardiac dysfunction, their B natriuretic proteins, or BNPs, are markedly elevated, way more so than severe COVID-19, and certainly way more higher than normal. Again, demonstrating that what seems to be the primary cardiac process here is ventricular dysfunction. Okay, so getting into the sort of more of the immunologic profiling of these patients, this is just showing you some longitudinal data, just what their CBCs look like. And one of the interesting things, and again, this sort of mirrors a little bit of what you heard from Mike about neutrophils. These patients also developed neutrophilia, but really many of them profound neutrophilia. So look at these ANCs of 45,000. That's a marked amount of neutrophils. And in fact, it's not just neutrophils, but they were making metamyelocytes, promyelocytes, all these immature forms. For some reason, they were developing a leukemoid reaction. Their bone marrow was churning out neutrophils. And I'll come back to that thought in a little bit. While they were lymphopenic to begin with, you'll note that some of them also, concomitant with their neutrophilia, developed a lymphophilia, where their lymphocyte counts also began to rise in the recovery phase. And we're still in the process of trying to understand what this all means. And again, coming back to this idea of Kawasaki's disease or not Kawasaki's disease, I think most of the world is now sort of settled on that while this is Kawasaki's-like, this is not Kawasaki's disease proper. I think this table sort of demonstrates that, where we have two patients that don't even meet Kawasaki's disease criteria. The other two, at best, meet incomplete criteria, and of those that they meet the most non-specific criteria of like rash and red eyes. And so most of these patients really look, while there's some similarities with Kawasaki's, look like something different. Okay, so we profiled, and I'm only going to really show you a subset of what we've done. We're going to start with the cytokine data. We profiled cytokines on these patients. We measured a total of 10 different cytokines. What you'll note is that really only 5 of these seem to be relevant. The others were not really positive in the cohort. So IL-10, TNF-alpha, interferon gamma, IL-6, and IL-8 showed some positivity. So I'm going to focus down on those 5 cytokines from here on out. So this is a heat map just sort of showing you the architecture of the cohort. And the other thing we kept track of was who had co-infections. And what you'll note is that having a co-infection with either other bacteria, other viruses, messes up your cytokine panel. You get elevations of a number of different cytokines when you have multiple viruses in your system. But we can keep track of that. And just to sort of make this slide simpler, I'm just going to focus down on the pure cohort, the ones that had no co-infection. What you'll note is that if you have minimal disease, you're basically not hypercytokinemic. You're not making a lot of cytokine. And if you're if you either have severe or MIS-C, you are hypercytokinemic, but it looks sort of qualitatively different, right? I mean, it looks like, perhaps there's more IL-10 in the MIS-C group, maybe some more TNF-alpha. The interferon gamma is intermittently positive, depending on the patient, but there seems to be at least a clear distinction between MIS-C and severe. And you can follow this over time with therapy. So this is just the 4 patients for which we had longitudinal data. And what you'll note is that in the MIS-C group, once we began therapy, and therapy for MIS-C is mostly IVIG and glucocorticoids, you can see a pretty rapid normalization of all of those elevated cytokines in these. The severe group, we're not going to have time to get into. It's complex. They see a lot of different kinds of drugs. You can see on this slide different kinds of changes in those cytokine panels. But in general, when you treat the inflammation, the cytokinemia tends to resolve. And as I sort of suggested, if you compare severe to MIS-C, and you look at, and we did a number of things, we tried a number of sort of sophisticated ways to look at this, and really at the end of the day, what we did is an exploratory logistical regression model, and just took the two cytokines with the highest beta parameters, and then said that was what our metric was going to be. And that came out to be IL-10 and TNF. And if you sum those two cytokines together, you can distinguish the MIS-C from the severe group in that the MIS-C have elevations of these cytokines. Now, I'm not suggesting a causal pathogenic link. I'm not suggesting that we block IL-10. In fact, I think if anything, the IL-10 represents the body's attempt to maybe dial this back down. But at least as a biomarker of the MIS-C group, they tend to have higher levels of these cytokines compared to the severe, and certainly higher than compared to the minimal group where there wasn't really much cytokinemia. Now, I mentioned that the MIS-C group was purported to be post-infectious. I'm going to try and convince you of that now with some data. So if you look at PCR cycle thresholds as a surrogate for viral burden, what you'll note is that the severe group has low cycle thresholds, which is equivalent to saying there's a high viral burden in these patients. And that's to be expected. These are acutely presenting patients. They're acutely infected with SARS-CoV-2. In contrast, MIS-C, and we're able to do this with our in-house CHOP assay or in-house PCR because they're able to report PCRs that might otherwise be reported as negative because they don't meet the cycle threshold cutoff of outside labs, but they're able to actually tell us that, yep, there was a cycle threshold of 39 or a cycle threshold of 40, which are really, really high cycle thresholds to call, but they can give us those data. You can see that the MIS-C group, they may have some virus in them, but incredibly low levels because their cycle thresholds are very high. And the minimal group, as you might expect, is all over the place because who knows where we're catching them in their presentation. They're not there for their SARS-CoV-2 infection. They're there for another reason. They just happen to be infected, so they're all over the place. But I think the fact that what we're looking at is with patients with low viral load, these are patients that were infected sometime in the past, and they're clearing the virus. And interestingly, if you try and correlate that with their cytokine levels, and again, this is the whole cohort, independent of infection status, independent of whatever bucket you're in, minimal, severe, MIS-C, there is a correlation with IL-10 and your cytokine burden and your viral burden. Again, because perhaps IL-10 is this resolution cytokine, so as you're resolving your infection, your IL-10 is coming up. None of the other cytokines correlated, and I'm just showing you TNF-alpha here as a comparison because I told you that TNF-alpha plus IL-10 marked the MIS-C group, but it doesn't mark viral burden. This was data that Scott Hensley's lab generated with us, and this is the sort of other side of the coin, if you will, of the viral burden. So if this is truly a post-infectious process, then these patients should be uniformly antibody IgG positive, and in fact, they for the most part are. Almost all the patients had elevated IgG to both spike and nucleocapsid. The minimals, again, are all over the place because who knows where in their infection they're presenting. And interestingly, and perhaps maybe a little bit different from the adult group, a number of the severe patients actually did not make antibody responses. And if you correlate these antibody responses, the first thing to note is that those patients that make a spike response also make a nucleocapsid response. There's a very tight correlation there. There is not a statistically significant correlation with antibody titer and the cycle time on the PCR. Although if you sort of squint and look at that, you can kind of get a sense that there are sort of two clusters. There are patients that have low titers and very low cycle threshold times, meaning that they're viremic and haven't yet met a titer. And then there's maybe another group up in the upper right that made a high titer and have a low cycle threshold time. So again, there's the beginnings of a correlation, but the outliers sort of ruin the statistics on that. But interestingly, the titer did correlate with your BNP. So patients that made higher titers tended to have higher BNPs, i.e. more ventricular dysfunction or biochemical evidence of ventricular dysfunction. So if antibodies are important, are they therapeutic? So as a little bit of a detour, I'm going to share a little bit of our experience with convalescent plasma use. And we've treated 4 patients now with COVID-19, severe COVID-19 with convalescent plasma. And just as sort of like 2 examples, here's a patient that actually, interestingly, if you look at the lower left, prior to infusion of the convalescent plasma, had already made her own endogenous titers. And so giving extra convalescent plasma, giving extra antibodies, did nothing for her antibody titers. And unfortunately, it's not clear that it actually helped change her trajectory. As you can see, she ultimately expired from her disease. In contrast, here's a patient that had very low titers and then gets transfusion of the convalescent plasma product that had high titer antibodies. And you can see shortly after transfusion, his or her antibody titers quickly came up. And so it does demonstrate that you can actually give convalescent plasma and affect the serologic status of the patient and actually give them positive titers in their serum. As to the efficacy of the product, it's difficult to say. We simply just don't have a large enough experience to be able to say, did it help, did it not help? But I think that there's at least a serologic correlate that having your own antibodies, it's sort of like what Scott said. If you already got your own response, vaccination is not going to help, whether that's a passive vaccination or an active vaccination. But if you don't have antibody titers, then perhaps a passive vaccination in the form of convalescent plasma might help, because it at least could give you protective levels of antibodies in your serum. So finally, I want to end on one more point that has been brought up about SARS-CoV-2 infections, and that's the idea that this might be associated with a small vessel disease, with a microangiopathy. Now, we typically think of microangiopathy as being associated with a whole host of different causes that you can see on this slide, and the list of causes actually has grown to a whole host of different other things as well. And so it's reasonable to consider that perhaps this viral infection is also another cause of microangiopathy. Microangiopathy can come as a result of both complement dysregulation and activation of the complement system, and can also come from direct endothelial damage. And endothelial damage can be measured in the form of schistocytes, or torn apart red blood cells, and in the form of elevated serum complement C5b9 or MAC complex, which is associated with endothelial destruction. And so we measured the soluble MAC complex in these patients, and you'll note that there was the minimal patients, and we don't have the healthy control cohort on here. We've subsequently got those data points as well, and I can tell you that even the minimally affected patients are above healthy controls. So even asymptomatic patients have some evidence of this microvascular disease and the evidence of soluble C5b9, but certainly the severe patients have a statistically significant elevation of this marker. And the MIS-C patients have a trend that, at least in this cohort, did not reach significance. Interestingly, if you look at which cytokines are associated with this, it's now a different set of cytokines, IL-6, IL-8, and TNF-alpha, that correlate with soluble MAC complex. That's perhaps not surprising, because IL-8 is a cytokine that is found inside of endothelial cells and is released upon their damage. So it would make sense that that would correlate with soluble MAC. And IL-6 and TNF-alpha as markers of innate immunity, perhaps, again, being associated with the endothelial damage makes sense. Interestingly, antibody titer does not correlate with C5b9, which to me suggests that the complement activation may not be associated with immune complex, which is what you'd expect if this was due to endothelial damage and not due to antibody immune complex formation. So this lack of correlation, I think, fits with the model that what we're measuring with our soluble MAC complex is indeed an endotheliolitis and microvascular disease. And we have histologic evidence of that as well. So you can see schistocytes on many of these patients, these torn red blood cells. I've pointed out some of these forms with the arrows here, and then in a zoom in, a nice picture of the schistocyte on this slide. And these are quite prevalent in these MIS-C patients. And then the other striking thing that we don't understand, but that we find and continue to find, are these BURR cells, these very spiky instead of smooth red blood cells, and they're basically just all over the place. You don't need to You don't need to be a hematopathologist to recognize they're just everywhere. And then finally, harkening back to the neutrophilia that we discussed and that we showed on our slides, these patients have toxic granulation in their neutrophils. So this is not a normal histologic appearance of a neutrophil. Those dark granules should not be there. That's an evidence of an angry activated neutrophil. And again, I'm reminding you of these very high ANCs that we saw. So summing these data up, you can see that the BURR cells are significantly increased in the MIS-C group. We're still trying to understand what that means from a physiologic perspective. The toxic granulation also highly elevated in the MIS-C group compared to the other groups. And the schistocytes, again, more prevalence in the MIS-C group, higher degrees of schistocytes in the MIS-C group. I'll point out that the 2 patients in the minimal group that had schistocytes just happened to be sickle cell admits. They weren't there for their SARS-CoV-2, they were there for their sickle cell, and that certainly can confound the schistocytes, and that may be why those patients were positive. So just to sort of summarize the takeaway messages, I think our experience corroborates that of other centers. We certainly need to understand the full clinical spectrum of these patients, but I think it's distinct from Kawasaki's disease, and understanding those similarities and distinctions may help us understand the disease better. There seems to be a clear cytokine profile of MIS-C that's different from severe COVID-19. That's certainly different from the asymptomatic patient. And understanding which are biomarkers, which are contributors, I think can be helpful in understanding how we might intervene therapeutically and how we might make diagnostic and prognostic information about who might get this. This seems to be a post-infectious process. The patients seem to be almost uniformly seropositive, and if they're virus positive, their viral burden is very, very low. And then just to point out that we really need to follow up with this thrombotic microangiopathy or endotheliolitis that seems to be associated with the SARS-CoV-2 infections, that I think will have long-term implications for treatment and follow-up. And so we have ongoing studies to try and better understand that. So I think I'll just stop here. If there's time for a question, I'm happy to take that.
The health department in his county says that children do not spread disease. If they happen to get infected, they don't infect others. They don't spread very much. Do you know where this information comes from, and is it correct?
I'm volunteering for my child's school district, actually, on a task force. And so I'm on a call with all these parents. And someone brought that up somehow. I don't know where that comes from. I know of no data that suggests that children do not transmit the disease. They absolutely transmit the disease. Like that the epidemiology is clear on that. So I'm not sure where that concept is coming from, but I'm pretty sure it's wrong. Children, it's absolutely true that they're asymptomatic, but there's nothing that somehow prevents them from spreading the disease. They spew out the fomites like everybody else.